Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession. Welcome to the Docs with Disabilities podcast, where we delve into critical conversations shaping the landscape of medical education. In today's special series episode, we are honored to have distinguished guests, the student affairs deans and leaders from California medical schools, who have championed the cause of accessibility, inclusion, and justice in medical education. In our discussion, we explore the catalysts that fueled their commitments to fostering an equitable and accessible educational environment. We discuss their personal journeys into recognizing disability as a vital DEI or JEDI issue in MedEd, the pivotal moments that led to the hiring of specialized disability resource professionals, and the transformative impact of specialized support and an inclusive culture on campuses and the student experience. Our guests also share why they believe other institutions should consider this crucial step of providing support for students with disabilities, the strategic benefits, the lessons learned on this journey toward a more inclusive and diverse future in MedEd. Without further ado, let's welcome our guests.
Hi, my name is Lee Miller. I'm a professor of pediatrics and associate dean for student affairs at the David Geffen School of Medicine at UCLA.
Hi, I'm Mijiza Sanchez-Guzman. I use she, her pronouns, and I'm the associate dean of the Office of Medical Student Affairs at Stanford Medicine.
Hi, my name is Sharad Jain. I'm the associate dean for students at the UC Davis School of Medicine.
Hello, my name is Erick Hung. I use he, him pronouns, and I am the Associate Dean for Students at the UCSF School of Medicine.
Hello, my name is Guluma. I'm Professor of Emergency Medicine, and I'm the Associate Dean for Admissions and Student Affairs at the UC San Diego School of Medicine.
To kick things off, let's explore the journey each panelist took in recognizing disability as a critical facet of diversity, equity, and inclusion in medical education. It was evidence that the voices of students have been instrumental in fostering a deeper understanding of disability as a vital component of diversity. Listen or read along as this panel of deans describes their journey to disability equity in their programs.
Really, one of the greatest sparks here at UCLA was our student body. There was a newly formed student affinity group called the Disability and Chronic Illness Group. And it was really this group that launched our increased efforts to address the specific needs that students with both disabilities and chronic illness may have in medical education and in particular in the clinical setting. It also helped to foster a community of individuals with disabilities and chronic illness, as well as their allies, to increase representation, access, and awareness. Was so happy that it led to curricular change so that our learners are also better prepared to address the needs of patients with disability and chronic illness.
I had the same experience here at UC San Diego School of Medicine. The credit really goes to students who got together, formed a disability and chronic illness in healthcare and medicine interest group. We actually first encountered them when they approached office to see if we could modernize and make our technical standards more inclusive. And so we went through that iterative process with them, formed a committee, we revised our technical standards, and then the ball started to roll there. And they really provided that extra source of inspiration and galvanization that really helped us start to think about these things. And then we evolved to have a deliberate audit of our support, engaging the service of a consultant, and then just expanded from there.
Prior to coming to Stanford, I spent nearly 10 years at UCSF, and it was there that I saw the importance and value of providing support to our students with disabilities. And as both of my colleagues have mentioned, our students are always the biggest advocates. And being at UCSF was a great model for me, and I knew that it worked well, and was surprised when I came to Stanford and learned that the School of Medicine didn't have an in-house DRP. I later learned that many other medical schools use a similar model that we did of having the main campus provide these services to the entire campus.
Like Mijiza, I was first introduced to the issues facing students with disabilities when I was a faculty member and student advisor at UCSF. There I was fortunate enough to work with and learn from the wonderful Dr. Meeks as we partnered together to help arrange accommodations for several students. That work really exposed me to the challenges faced by those students and demonstrated that there is an expertise required to support those students. And not surprisingly, the same issues came up when I transitioned to UC Davis. We've been working with many colleagues, like this whole group, to improve the support that's offered based on the needs articulated by our students.
I have been in this role as Student Affairs Dean for about a year and a half now. And before that, I was a residency program director for a decade in psychiatry. And I will say that the GME world at UCSF always looked at the undergraduate medical education world at UCSF with a ton of envy. In residency training, we're navigating so many issues around disability advocacy and making sure that we get accommodations for our residents and fellows. And we would often say, well, how is the medical school doing it? And the medical school was, of course, like light years ahead of residency and fellowship programs. And so I came into this role actually excited that I was going to be stepping into more resources than where I left, and just had a huge excitement for that.
For one of our deans, the desire to build an equitable training experience for learners with disabilities was both professional and personal.
For me, I live with an invisible disability I'm hard of hearing, and I remember struggling when I was in grad school trying to self-accommodate because I didn't want to ask for help. And I didn't want any of our students to have that experience. And so I think in my role, it's been very important to me as a person with a disability to make sure that our students can thrive and I can remove any stigma for them so that they can have the resources they need.
Building on the drivers of disability inclusion, our panelists discuss the importance of employing specialized disability resource professionals in medical schools to enhance disability inclusion. I asked them what factors or events served as the catalyst or perhaps the tipping point for their decision to hire a DRP.
Part of all of our jobs as student deans is to continue to advocate for resources, and especially around disability advocacy and making sure that we better help students navigate the accommodations process. We actually recently went through an analysis of all of our pain points around communication, resources, people, and what we continue to find, even with disability resource professional and person who is helping to navigate that, is that we could always use more, right? And thinking about how to make the value proposition for that so that students can feel that the process is streamlined and that there's autonomy in the process and choice, and to make sure that, especially with faculty, that we continue to prioritize the faculty development needs that are so important to make sure that students with disability and accommodations in the learning environment, especially in the clinical learning environment, don't have to always reinvent the wheel with what works in one service compared to another service.
At UCLA, again, in large part thanks to our students, we gained really a deeper appreciation for the complexity of accommodation needs, particularly in the clinical setting. And we felt so fortunate, Lisa, to have you join us as a consultant to review our practices and resources, including our technical standards, and to make recommendations that we could share with the dean of the medical school. We also reviewed the AAMC's white paper on accessibility, inclusion, and action in medical education from 2018. All of the above really fueled the medical school's interest in providing greater support for our students and for hiring a DRP for the School of Medicine separate from the main campus?
I would say, and sometimes just fortuitous, we had a new leadership team that came on board. And as often happens when new leadership, a new vice dean, a new dean for curriculum, and of course, I was relatively new in my position. But as this new team came together, it often happens when you have these teams, there's an introspection and a taking stock of what's going on and looking towards new advancements. So that was one component of what I think is a tipping point. The other, you asked about the personal experience, was actually we admitted a student with physical disability, and their classmates rallied around them to really understand how they're impacted in our environment. And so it seemed that really galvanized the whole school. We're all thinking about it. We engaged campus partners to modify our facilities. And just that process of engagement opened our eyes to think, okay, what if we admit another student with other disabilities? How can we get towards kind of a universal design sort of perspective? I know that universal design is a big undertaking, but it was just inspiring to think about that and seeing we need to be ready for other students like this.
For us, I think it was definitely having you, Dr. Meeks, come to our campus, like Dr. Miller said, to really do a deep dive in our practices here. And I think our students have been really strong advocates of asking for this to happen at our school. And our leadership listened. I think people understand the importance of having a dedicated, specialized DRP in-house. And like I said before, I think we've learned from models in other schools like UCSF that those models work really well. And it would be in our best interest to do that for our students.
We have identified a staff member who is undergoing training to learn with Lisa, which is great, around how to support students with disability. And she's done a really wonderful job in the 6 months she's been with us. And I think for us, the tipping point was really the number of students who have accommodations has really increased exponentially over the last couple of years, and really realizing that we need to have this expertise to support these students in a way that is going to ensure their success. So I think that, as well as student advocacy, we've had a student who really pushed us in really important ways so that we took this seriously and invested in it to help him as well as other students who are coming behind him. It's been really great to get this going.
Each member of this panel represents different stages within an integrated specialized DRP model. Given their varied experiences, I asked the panelists to describe the tangible impact that the employment of a specialized disability resource professional has had on their respective medical schools and the benefits of this structure.
I think for us, we were lucky. So our disability services have been provided by the main campus through the Office of Accessible Education. And the person who was in that role that was dedicated to the School of Medicine is who we hired. So I think we got really lucky and was able to get someone who was already familiar with our students, familiar with our curriculum, and understood very intimately how to support our students. And I think it was a beautiful transition. So she came with a very warm welcome. People were really excited to have her on board, and she's hit the ground running. She's been able to really step into the role and masterfully just take off with it. So it's been really great.
We are relatively new in the process. Our DRP basically just started a month or two ago. And I have to say, the impacts I've seen from just talking to her are as follows. We noticed an increased number of students reaching out and directly meeting with her. So again, our students used to go to campus for their disability accommodations needs. Now this person's in health sciences. I'm even talking to her. That's a new thing that never happened before. We're learning from her. We know there are an increased number of students reaching out and meeting with her. When she first switched on her calendar, her office hours were booked up already. The other thing that she's told me that never used to happen is course directors are preemptively reaching out to her, seeking ways to make their courses more accessible. And this strikes me as a sudden change. It's more proactive. They're thinking about how to, a priori, get their courses designed in a way so that it's not just a reactive posture anymore. So those are two things, and I anticipate good things to come.
I think, Pama, what you just said about connecting with your DRP and that increased communication has been one of the greatest impacts. And I've learned so much from the process. I think that We're providing a completely different level of support for students, student satisfaction with the recruitment of the DRP, specifically for the medical school, has soared. We hit the jackpot with the recruitment of Grace, thanks to Lisa's support. Another impact that has been demonstrable is that we've had much stronger support for students who are navigating the application process for testing accommodations from the NBME for both the USMLE Step 1 and Step 2 exams. Very notably, our DRP has also made a huge impact on our faculty development efforts. And then finally, I know that our DRP has been very much engaged in taking a fresh look at our technical standards that are now being vetted across the whole University of California system. So the impact has been palpable.
Yeah, we have our students, we have our faculty, we have our course coordinators, we have our disability offices, and we often are working at the campus level with the chief accessibility officer. And so I think our DRP has been really effective in trying to navigate all of those different conversations and to make sure that the kinds of resources and workflows and ways of streamlining what sometimes feel like a really bureaucratic system, that we are paying attention to that and are constantly in evolution and changing. And our students are asking for this. They're at times demanding this, right? And it's really important, I think, for us to show our students that it's not just their advocacy that is going to foster and create change, but that we're also investing in faculty and staff and people at the university that are also partnering with them.
That's amazing. I wrote a paper last year on QI and how across the med-ed continuum, we are married to QI in every single aspect of everything we do, except for disability inclusion and disability support. So I love to hear this kind of iterative examination of what you're offering and where there are gaps and how you're continuing to address those, Erick, with your DRPs. Sharad, anything before we go on?
I just wanted to say, echoing what others have said, I think there's a huge diffusion by having a staff person identified as supporting students with disability. And so, as other members have mentioned, people are reaching out to her to understand, how do we do this better? How do we think about whatever accommodations they may need to succeed? And the other thing I think is we're being much more proactive in terms of helping these students. So whether it's MBME accommodations or even the transition from the pre-clerkship to the clerkship phase, we are much more deliberate about making sure in advance that they don't run into any trouble, or they minimize the trouble that they run into as they make the transitions between the various phases of our curriculum.
What strategic benefits have you observed because of investing in specialized support?
We've talked a little bit already about not only the additional support for students, really having another person to go to help them navigate the process, but also having another support person for faculty and for our course coordinators to think in a very proactive way. How do we make things more accessible, and how do we minimize all of the paper cuts, the microaggressions, and at times the macroaggressions that take place for students with a disability in the learning environment, trying to get their accommodations met in equitable and productive way. And the DRP can be really important in working with our faculty and our course coordinators and to identify what future gaps do they have and how do we think about addressing those gaps with staff development and faculty development. That piece I feel like is so important, not just for meeting the bar for accommodations, but actually going beyond that and creating a culture of anti-ableism.
I love what you said, Erick, and I would just like to echo the benefit of having the DRP for the faculty. One of the things our DRP did in her role shortly after joining our team was to shadow our faculty in the 9 core clerkships. And every time she has a shadowing experience, her eyes are just wide open. She really sees herself as a partner now with the faculty, and she wouldn't have been able to do that having not been in their shoes and to be able to be in the spaces. So I think that makes her a more powerful advocate, not just for the students, but for the faculty.
I wanted to just add that there's a huge symbolism at the institutional level of having somebody identified in this role. We like to pride ourselves on recruiting a really diverse student body. And I think this shows that commitment by supporting all students who matriculated at UC Davis. So I really think that support for students with disabilities is a very tangible way that we are actively working to create that safe and inclusive learning environment for all of our students, including those with disabilities.
It's interesting you say that because I was also wondering how having a specialized DRP, all of the things you're talking about, helps to create this more inclusive and equitable learning environment. Lee?
I think that it has really helped to destigmatize disability in medicine and to cement its position within our JEDI efforts and really to develop a more collaborative, cohesive, and inclusive community. So that has been one of the major strategic benefits of this initiative.
When I look at disabilities in an equity and inclusion framework, I really see it from two major frameworks. We've all seen the Norman Rockwell paintings. We grew up seeing that in terms of the archetype of what a doctor is. And when I think about equity and inclusion in school of medicine, I think about breaking molds. It's no longer about trying to a square peg in a round hole. The hole now changes shape to accommodate who's being put into it. So I think when we change the archetype of who is a doctor, it creates a more inclusive environment for all. The second way I see really being intentional about including students with disabilities in our med school is, at least in our school, our diverse student body is well represented by students who come from low-income immigrant and refugee backgrounds, don't have access to diagnosis for disabilities when they're in elementary, middle, and high school. And many of these students could get by in high school and college because of their sheer brilliance, but when they show up in medical school and have to manage the rigorous curricula in medical school, they actually suffer because of that. And I think having a very intentional approach to disabilities prepositions our support for these students, meaning it has impacts for all students in a diverse population. And having that prepositioning of support can mean the difference between success and failure of a student from a non-majority or low-income background.
Introducing the concept of specialized support for students with disabilities undoubtedly brought forth its share of challenges and reservations. As we navigate this topic, it's essential to acknowledge the complexities that administrators and educators faced during this transition. So I asked our panel, what was your biggest challenge in starting this process?
One of the biggest challenges for us, and again, our disability service providers started just a couple of months ago as well, so this is all very new and fresh. One of the things we're seeing is just the transition between the Office of Accessible Education to having it all in-house, right? And so the things we're thinking about are systems and how can we make this a smooth transition for our students who are already receiving accommodations or who have already registered through the Office of Accessible Education and now being required to register through us. We want to make it as seamless as possible. We don't want it to be a burden on our students who are already registered. And so I think one of the things that our disability services provider has been thinking a lot about has been how do we transfer the data that has previously been housed in the Office of Accessible Education? Is there a smooth way to transfer that data over to the School of Medicine? How do we make it so that students don't have to retell their story all over again to us if they've already registered with the Office of Accessible Education? So those are the more logistical things that we've been thinking about. I think it'll be much smoother once this new class comes in and they know that they're going to start with us. But it's just the transitional pieces and logistical pieces that have been a little bit challenging.
To add to what Mijiza said, we first had to do a fair amount of campaigning on the main campus and have buy-in from campus leadership and from leadership of the main campus's Center for Accessible Education. And that took time. And there were certainly concerns about who would be providing the resources to support the recruitment. And then when everyone came together and agreed on the plan, we had many of the issues that Mijiza described, and that is the new DRP taking over the student caseload of those who had been followed previously at the Center for Accessible Education. But that was resolved very quickly as Grace took on getting to know all of the students in the School of Medicine. I was very concerned that creating this new role would create many more administrative challenges, but I think really thanks to the leadership on the main campus and at the medical school, most especially our DRP, the transition was a much smoother one than we anticipated.
At UC Davis, we continue to have some challenges working with main campus, and we're working through those. And I think having a staff member starting to be identified in this role has helped us tremendously. And I think our buy-in with leadership is really trying to show them the research that many, including Lisa, have done to show the value that this brings to our student body, our student success rates, et cetera. So I think that was really the catalyst for even moving this direction. But I do think having the experience from these other schools represented today will really help us push forward in our ongoing negotiations with main campus to try to bring more of that inclusiveness within the School of Medicine itself. So I'm hoping that we can really get to where these other schools have gotten in short order.
Another thought is I think that the transition was much smoother because our DRP participated in a fair amount of professional development activities for her colleagues who are on the main campus. And that really helped to solidify the relationship and I think contributed to the smoothness of the transition.
I'm sure, as with any adjustment or any change in structure, there are some lessons learned. What lessons have been learned in this process for all of you, and what advice might you offer other deans considering a similar approach?
I think that my recommendation would be to reach out to folks who have programs in place. And that's certainly what we did. And we keep coming back to UCSF, but we learned so much from our colleagues there. And Lisa, you were wonderful in connecting us with folks at other institutions who had established an independent DRP program at the medical school level. So I think that learning from the experience of colleagues at other institutions would be the first bit of advice. The second thing that I would do to fuel the buy-in at the dean's level is to share with deans both the 2018 AAMC white paper and the 2021 AMA white papers that really highlight in particular the strong recommendation for a DRP specialist at each medical school. So I think sharing the literature with leadership at the medical school level and having the additional support from folks who have navigated these obstacles already, those would be my 2 bits of advice for colleagues.
I also think it comes back to what our core values and our mission is. And I think for many of our institutions, we have a clear and a strong commitment to creating a diverse workforce, a workforce that is desperately needed from our patients and communities. And if you think about recruiting a diverse workforce and having that workforce be successful in medical school and making sure that every single student crosses that finish line with specialized attention and resources, and those resources are going to look different for different students, you need to invest in specialized support. And I think that coming back to that with your leadership team is just so incredibly important, because we often say, well, what we used to do in the past is going to be just fine for the future, but it isn't. We know that if we have a strong commitment to creating the diversity that we all want for the patients of today and for the patients of tomorrow, that we need to create more specialized ways to help our students cross that finish line.
I would agree with everything my colleague said and only add, I always tell the students that they underestimate their power, and our student voices are so powerful, and our leadership, I think, really care deeply about our student experiences. And so I think the students have been just as instrumental in these processes as we have been as leaders in getting these positions solidified in the schools.
And I wanted to add, I think this really is a movement to bring culture change to medical education and to really say we are committed to that diverse workforce to meet the needs of our community. We need to invest in this. And that is just really important that we take this responsibility seriously and make that investment and support students to succeed.
A few of you have touched on this subject of how this ties into your DEI or your JEDI efforts. Can we talk specifically about how having specialized support helps align with the overall diversity, equity, inclusion, and justice initiatives at your school? And how does this contribute to a more comprehensive and intersectional approach to DEI and JEDI?
It's a really important question, and it's a big question. So far, we've talked about primarily the student experience. And that is first and foremost, I think, for many of us as student affairs deans. But it goes beyond that in that it is also about our curriculum, what we teach, what content we teach, how we create at times ableism in the curriculum, and how do we combat that. And the DRP, I think, is one of many people to think about not only the student experience, but the curriculum, the learning environment, our workflows and communication pathways. And all of that is, I think, just so critical for diversity, equity, inclusion. And I'm going to throw in there anti-oppression efforts. We think about the goal of dismantling oppression that exists in medicine, oppression that happens with our patients, oppression that happens with our students, oppression that happens with faculty and staff too. And I think that while this position is just one small piece, I would argue a really important piece in the much larger equity, belonging, inclusion, and anti-oppressive efforts, it is really, I think, such a foundational one. And as we think about continuing to dismantle oppression in all of its various forms in the student experience and in our curricula, in faculty attitudes, and in technical standards and policies, that this position really works in tandem with everyone else doing this work together.
I'd like to add, I look at it also from the perspective of what benefits equity and inclusion bring to our world, our institution, and whatnot. And in addition to looking at it from a restorative perspective, Eric was talking about, you can also look at it from an optimization perspective. For example, in terms of having diversity in a clinical team, whether it's gender, ethnic background, there's ample evidence that shows that diverse teams actually think and create in a better way than non-diverse teams. That's bare bones, bottom line, get productivity improvement sort of perspective. We also know that, for example, patients from marginalized communities are more likely to follow the guidelines given to them by a doctor they share commonalities with. So it's easy to see how extrapolation to physicians with disabilities, how they'd impact the clinical team, department, and their patients.
I would also add that across all of your DEI, JEDI initiatives, anti-oppressive initiatives, there will be individuals with disabilities that are members of all of those traditionally marginalized, minoritized groups. And so it's incredibly important for groups that are already facing so many barriers and so much stigma to make sure that their disability-related needs are met. And Eric, I love what you were saying about the anti-oppressive lens, because when you address these things together and you recognize and honor the connection between all of them, you help every group to be able to have success in your schools because they're having access. And I think that's an important element. Eric and Lee, you had specialized support or have benefited from specialized support the longest. Eric, you have had specialized support since 2012. And Lee, you've had it since 2022. So, I mean, I'm not a mathematician, but it looks like a decade for what was happening at UCSF to kind of spread across California. So I imagine that the answers will be very different for this next question, but how do you measure the success of having the specialized support? What metrics or indicators do you use currently, or do you plan to use to show the impact of having a specialized DRP?
It's a great question. And I think that this question ties back into your question of how do you make the value proposition for a DRP? Because at the end of the day, leadership often wants to see outcomes and data. And I think it's really important to think about how a position like this is going to be successful and how are you going to measure that? And I think that we often start by measuring what, in my opinion, is the most important thing, which is our student experience and satisfaction. I think that if students with disability and accommodation needs feel like the process is just a little bit easier and has a little bit less micro or macro aggressions in that process, then I would say that that is worth it just in and of itself. And yet it goes beyond that, right? I mean, I think it's around thinking about how we create reporting systems and understand if accommodations are being met effectively in the learning environment, and for students to be able to report that. And that can be a way of tracking that. That is something that becomes really important. I think it's also important to think about how do faculty behaviors change and how are those behaviors influenced in what we teach? So, for example, taking a look at the curricula that we have, how is that shaped? Kama had mentioned universal design. How is that being incorporated in the curricula? How do we think about our vignettes? And do our vignettes have or promote ableism in medicine? There are so many ways in which things go beyond the student experience. And while the student experience, I think, is first and foremost, I think there's many other ways to track and to measure success. I would say most importantly, it's about academic progress too, and advancement, and seeing students get into the residencies that they have always dreamed of getting into, and not necessarily shying away from career specialties that they feel that their disability may not necessarily have found a home in. If we can realize that and have students actually move towards the things that bring them passion and joy, then I would say that tracking that is probably the most important thing that we could track.
Erick, I agree completely. That was so well said. Really, the most important things have been monitoring student satisfaction and ultimately student success and crossing the finish line and being able to pursue their dreams. We, of course, don't have the long track record that UCSF has. I think one measure of the success of specialized support is really the caseload. And within the first year, our DRP's caseload doubled. And I think it's likely related to more students feeling comfortable with requesting accommodations. And I suspect that we had many students who did not pursue navigating the accommodation process before Grace's arrival. I think that we also rely on feedback on curricular change and how we've been able to improve our undergraduate medical education programs with a much different lens thanks to our DRP. And then finally, besides internal student surveys, the AAMC is adding to the graduation questionnaire questions to address the satisfaction of learners with disabilities and chronic illness. And so that will be very important feedback for us as well.
We ended our interview with a reflection from the leadership perspective. I asked why other institutions should seriously consider taking the step to provide specialized support for students with disabilities in medical education.
It's the right thing to do.
I think philosophically, we've made a commitment to the students we admit, and we need to honor that commitment by offering them the support they need to be successful. And this is one way to do so.
And as we've said, we need to build a diverse workforce that reflects the demographic characteristics of this country, which in the long run will improve access to quality care.
I would echo those. And I think leadership has a broad pool of stakeholders that they attend to, including not just learners, but staff and faculty. And all too often in medicine, we're focused on the customer and not so much the people who are providing the support to the neglect of staff and faculty. And I think really attending to this shows a person-centered mindset and framework that people can see is just good. It's the right thing to do. It's the good thing to do.
And for me, it all comes back to the patients and communities whom we serve. Lisa, as you said, if you are a patient and you can have a connection with someone who is living with a disability and that someone is your physician, and that connection becomes just that much closer because of that shared experience, I think that that is what we're aiming for, and we need to create all of the pathways to help get there.
In this podcast episode, our panel emphasized the importance of disability resource professionals in addressing the specific needs of students with disabilities in medical education. They also addressed the need for standardization, faculty development, and collaboration between students and administrators to create inclusive and equitable learning environments. Recognizing disability as a diversity, equity, inclusion, and justice issue is vital to ensuring that all students have equal opportunities to thrive. We encourage you to review the 2018 AAMC report lauded by many of our guests, as a roadmap for improving services, and to review the resources offered through the Docs with Disabilities website. This podcast is a production of the Docs with Disabilities Initiative and is supported in part by the University of Michigan Medical School Department of Family Medicine and Disability Program, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The opinions on this podcast do not necessarily reflect those of the hosts, their respective institutions, or the funders. This podcast is released under Creative Commons Attribution, Non-Commercial, Non-Derivative License. This episode was produced by me, Dr. Lisa Meeks, and Nicole Kim.